Good morning and welcome to the monthly work session for May 20th, 2014. We are now in the televised portion of our workshop, and this morning we are happy to have our Health Benefits Task Force report by Mitzi Cochran, who is our CFO. Welcome.
Good afternoon, everyone. I think I'm on. Can you hear me? Okay. Can you hear me? Okay, great. So in the beginning, I was trying to figure out, should I present? Should I let everybody present? Or, how should we do this? But we have only an hour, so in the interest of everyone's time, I'm going to go ahead and talk. I know enough to be dangerous, but I have people who are way smarter than I am sitting behind us. The camera's not really on them, but so if we have any questions that I'm unable to answer, they will definitely be able to jump in and sit next to me and answer those questions for us. So let's go ahead and get started. You guys have a read ahead that you were given. And ultimately what happened was last summer, I guess, or maybe last spring, you guys went down to Charlotte County with the superintendent and did a visit to their on-site health clinics that they had and saw the savings that they were able to realize by making an investment in health care and having on-site clinics. Also, the Affordable Health Care Act and the implementation of health care reform was right around the horizon, so the superintendent decided to create a task force to kind of take a look at what we could do in the district to kind of offset our rising healthcare costs and implement a more robust wellness program. So we did that. We created a task force. The members of the task force, we had Aon. We had two members from Aon who are our broker that we utilize, two members from SCTA, Barry Dubin and Pat Gardner, the executive director and president. They worked with us. Roy Sprinkle, the director of HR, and Susie DeBose, our wellness coordinator, Lynn Peterson, our risk manager, and myself. So we began meeting in October. For those people, I want to thank them very much. They attended every single meeting. We met monthly. That's a lot of commitment, and they all remained very engaged. Worked very hard to kind of review all of the different options that are out there. There are many, and there's a lot of information out there, so just to get educated on everything takes quite a bit of time. So for that, I thank them all very much. So first, we kind of looked at on-site health clinics. On-site health clinics can offer a great deal of benefits for you. You can do your primary care there. You can save on that. You can do prescription medications. You can become more robust and actually do diagnostic services, x-rays. You can coordinate your workers' compensation, make that your first line of care. If you have, if you've had on-the-job injuries, you could send your employees there. You could increase your, if you had off-duty hours or, outside of the duty day, you could increase your productivity, keeping people at work. So there are a lot of potential benefits to having on-site clinics, but there are some cons to that. There is a large capital investment that's involved. Even if you have space available within your district, you still have to retrofit that for a medical facility. You have ongoing operating expenses for physicians, medical personnel, administrative costs. You have, based upon the size of our district, you may need more than one site, North County, South County, Central County. And then the benefits are usually seen on the claims. We're fully insured, we pay an insurance premium. So for us, that benefit may more be seen on a reduced cost of premium. In making that large capital investment may be more to the benefit for Florida Blue because they would have less claims to pay. And again, if you don't have the extra or the longer hours, or you only have one site, it may be less flexible for your employees. So we kind of weighed those pros and those cons for the on-site health clinics. And based on that, we kind of made some conclusions, which were on the next page. And basically for us, we found that that service delivery model really does work best in a self-insured climate. Charlotte County is self-insured. We did find PGT has an on-site health clinic also. They're self-insured. So for most of the places that had an on-site health clinic where they were seeing cost savings, it was because they're self-insured, so they're seeing the savings in their claims. The district is fully insured, so we've transferred the risk to Florida Blue. So for us, the only hope that we would see in terms of savings would be in a reduced premium. So again, the large capital investment required for that.
They're self-insured now. Were they self-insured before they went to the on-site clinic and then switched over to a self-insurance?
They were self-insured when they opened their on-site clinics.
So that they had been self-insured previously to opening the on-site clinic. Thank you.
Mm-hmm.
Do you have any idea how much long it would take us? You said to break even with our capital expenditure if we did something like this?
We would have to actually do a feasibility study. We didn't want to invest any dollars, in actually doing that before we, to do an actual study on something like that to determine that actual cost. We have a feasibility study that was done at Lee County. They are self-insured. I'm not sure. Do you know exactly what the payback period was? I know that at the end of 5 years, they had a net present value savings. I think it was $3.8 million. And that was...
End of 3 years?
5.
5 years.
5 years. And that was amortizing their capital investment annually.
Do we think that
and
with
they're
this
self-insured
committee that we had the expertise to make some of these decisions, that this may or may not affect us or may not be a good model for us? I mean, there are other consultants in the business that would have looked at this differently.
There may have been. I mean, I think that, it is there is a capital investment required. There is the savings the costs and the savings that are to be had the savings are in the claims. There is no doubt that the savings are made on the claim side, and we do pay a premium. So I think no matter who was sitting on the committee, that the thought process would probably be the same. There is a savings, whether that savings or what the payback period on that capital investment would be for fully insured. I mean, we could do the analysis. It would probably be substantially longer than the payback period for self-insured, because you don't see the return on the claim side that you would on the premium. The true beneficiary, if we were to do an on-site clinic and be fully insured, the beneficiary is the insurer. Ultimately.
So that really doesn't make any sense.
That's ultimately is. So to be perfectly honest, the next step that this task force took was, is there a rationale then to look at being self-insured? So we did actually go and take that next step on, should we look at being self-insured? Are we missing something by having that risk transfer? I mean, there are truly benefits to transferring risk. I mean, you pay your premium and you're done. You don't have to necessarily think about it much more. But what is that cost? What are we paying in terms of transferring that risk? Because so many entities have chosen to be self-insured. And why are they doing that? I mean, Sarasota County government is self-insured.
Yes.
I mean, we've seen the downside of self-insurance. I mean, it has made the papers. But if managed properly, is it something that we should entertain? So we did take a look at that, which are on some of your next slides. So,
Mitzi, before you go on,
sure.
You're talking about passing on the risk to Blue Cross, but don't we see past claims and future premiums? So I mean, we're really just deferring the increase if we have large claims.
Correct.
Right?
Which we'll discuss in what we're anticipating for next year's premiums for next year. But yes, that is a true statement. So when we started looking at self-insurance, we kind of determined that in all of the premium payments that we make, which includes our retirees, our COBRA dependents, and what the district pays itself, we pay about $43.5 million in premiums. Of that, we determined about $5.8 million was for the administration of our plan. So the administration includes, obviously administration, but there's taxes and fees associated with that. So it isn't just, and then obviously the assumption of risk. Yeah?
Would we be required to pay these same taxes and fees? I mean, as a government entity, would we be tax exempt?
We would not be paying the premium tax. We would be paying...
And how much is that, ballpark?
Oh, I don't know what the
all right.
premium tax
Well,
is.
somebody back there will find out for us
somebody
and
will
yell it
tell me
out.
exactly what that means. They're back there scrambling their papers.
So there'd be a premium tax we wouldn't have to pay.
Correct.
And what about the other fee? Is that the Affordable Care Act fee? How much is that? And would we still pay that?
There are 3 fees associated with Affordable Care, which we'll get into as we're
I'll
going
wait
through
for
it.
that.
But
Okay.
one of them is a health insurer fee that we do pay, and when you're self-insured, you won't
I
pay.
think we got a number.
You have a number?
Yeah, so the state premium tax is about $120,000
Oh,
annually. The health insurance fee, the other one you were talking about, is $782,000.
okay.
That's $1 million on top of the 5.8.
So okay. So if you take a look, we'll just kind of quickly go through the difference between a fully insured plan and a self-insured plan. There's some diagrams. So on the first diagram, on the fully insured plan, Sarasota County Schools pays a premium to Florida Blue, and Florida Blue holds the risk. And Florida Blue then pays our claims. They pay the taxes, they pay the health reform fees, and they pay for the plan's administration. So basically, we make one payment to Florida Blue, we're done, and they pay everything else. In the next slide, you'll see on a self-funding plan, Sarasota County holds the risk, and we pay claims. We would also pay a stop-loss premium. That way, you're able to mitigate some of your risk. We would probably select $250,000. So any one individual whose claims exceeded $250,000, this particular policy would kick in and take over. So you would kind of limit your overall risk on any one person.
It's
And
like having a $250,000 deductible on each policy.
correct. Right. So you would have that premium that you would pay. Then you would have your health care reform fees, which, like I said, there's one less fee on that one. The administration, which again, we would contract that out to a third-party administrator, and ASO, I think they call them. And then you have these other charges here, which are called IBNR and 11208, which we'll get into on the next slide. But incurred but not received reserves, these are not new to us. We are self-insured for workers' compensation, dental, auto, and general liability already. We have these set aside for all of those. Basically, they're claims that are incurred already. We've just not received them. They're an actuarial calculation that's made, and we set those aside at the end of every year. So this would be the same, albeit substantially larger than what we're used to setting aside, because health insurance is a much bigger number in comparison. The 11208 requirement is a little bit different. It's a state of Florida requirement for governmental entities. As I was telling Lori, I think at some point way back in time, somebody must have been self-insured and didn't have the money to pay the claims when they came due. So the legislature put a law into effect that said you must have money sitting in reserves, 2 months worth of claims sitting in your reserve account, so that in the event that you decide you don't want to be self-insured or whatever, for whatever reason, you have money sitting there to pay your claims out into the future. So this requirement for governmental entities in the state of Florida is to have 2 months of claims sitting in a reserve account, and it just sits there restricted and cannot be used. So this becomes the single event that stops a lot of entities, including probably ourselves, from making that leap from fully insured to self-insured.
And how much would that be?
About $6.5 million.
Ooh.
So yeah.
Ouch.
Yeah, it's a little bit of a stinger. So,
Do
on
we
the
get to
next
collect
page,
interest on it at least?
Yeah. On the next page is some assumptions that we've made to get to our numbers page, which, I'm the bean counter. I like the numbers. But so on this analysis, we've made some assumptions. The first one is that we're assuming that our claims are going to increase annually by 8%. For fully insured and for self-insured.
I'm hearing that husband reads through Wall Street and reads it out loud to me all the time, but that a lot of the insurance companies are coming in with single-digit reductions on their insurance premiums this year, 1 year after those that are renewing their plans. Some of them. Of course, that might just have been somebody trying to raise the flag and say the Affordable Care Act is a good thing.
It could be. We're not anticipating that for our plan for next year. I wish. We're also anticipating, in the self-funded analysis, that our reserve fund would accrue evenly throughout the year, that we would earn 1% on our reserve money. The administration expenses would increase by about 3% a year. Our stop-loss premium would increase by about 20% per year. That our plan would be reimbursed, that we would purchase the stop-loss premium at a $250,000 level, and that the state laws wouldn't change, that the reserve requirement would stay at 2 months. And that the health care reform fees, the assumptions are that the transitional reinsurance fee, which I'll get into more detail about what these fees are when we get into the Affordable Care Act piece, but for 2015 is $44 per member, and for 2016 it's assumed to be $26 per member, and the PCORI fees are estimated at $2.16 per member. So when you get to the next page, which is the analysis piece, you can see in 2014, like I had mentioned earlier, the premiums are close to 43.47 million, of which the retention piece, which is the administration fees and taxes to Florida Blue, are 5.8 million. So for 2015, this is the assumption that we would, do a self-insurance in 2015. It's a little late to be making that call right now, but that's what this assumption works from. It's saying on a fully insured plan that the premium is $46.7 million, and for self-funded, it would be just shy of 43.8. So that shows that the difference, or the risk charge, is 2.968. So if we were to self-insure, that would be what the savings would be, but then you have to, in the first year, by the end of the first plan year, you have to have funded that requirement for the reserves, which is at $6.4 million. So at the end of year one, you're at a net loss or a net cost of close to $3.5 million. By the end of the second year, again, that the risk savings was close to $3.2 million, but you're still at a cost of $724,000. But by the end of 2017, you have made basically to the general fund, recouped that reserve back to the general fund. You still have all of the cash sitting in the reserve account within your self-insurance fund, but you've kind of recouped back to the general fund that investment for that reserve.
So you've recouped your investment in 2 years.
Yes.
And actually, you still have the money. It's just in reserve.
It's just
not
sitting
that
there
you spent it.
restricted and unable to be spent, but within the general fund side, or wherever the funds that are paying into the self-insurance fund.
Mitzi, you mentioned some other school districts and counties and stuff that are that are self-insured.
Mm-hmm.
Did you get any sense on which direction government entities are going? Are they going more towards self-insurance? Are they going away from self-insurance, or they just kind of stay in flat?
I mean, I haven't seen that there's been a big shift one way or another from school districts. I think if they've been self-insured, they're staying self-insured. If they're fully insured, they're kind of staying fully insured. I mean, I can ask Aon if they've seen a big shift one way or another.
I would suggest that most of the school districts, once they've gone self-insured, they stay self-insured.
And obviously, the reserve, the 2 months reserve, is a big
Heavy
issue
lift.
starting out with
Just-
anybody, particularly with the district that has no reserves.
Correct. I think that's the big stumbling block currently for anybody who wishes to make that move.
Collier County is doing this? Collier County is...
Are you self-insured?
No. Collier is?
Mm-hmm.
I'd be interested in knowing how many school districts in the state that are in the medium size, which is our size, are
Are
self-insured. And I think it is a heavy lift, but here's the question. Is the heavy lift beneficial in controlling those outer year costs when we're looking at 8 to 10% increase right now per year? I mean, when you have such a big number, 10% is a lot of money. Are we going to be able to, in talking to Charlotte County last year, they said that they had held tight on their costs for the last 3 years and that they really hadn't increased their budget in health care at all. It was, what, $13 million?
I was surprised that not only breaking even, but coming out ahead in a very short time. But maybe we haven't really looked at those numbers as closely as we need to if we wanted to go further. Because I think I would want you to sharpen your pencils and look at it a little closer. And now, the administration. Would we be processing, or we would have employees that would be processing the claims?
No, I think that the plan, it would be my desire that the plan would be that this would theoretically be absolutely invisible to our employees, that we would have a third-party administrator, that they would have a card just like they normally have a card. Everything would be pretty much invisible to the employee. The administration would be handled by a Florida Blue or a United Healthcare or somebody else out there. It's just that the plan is actually...
Right, so there's not somebody sitting in the landing saying, you will pay this claim, but not that one, and no, okay.
Mrs. Zucker?
Does this impact us of, like, we're talking about the one clinic. So how would it impact us if we needed two? Because this is a long county. So would those numbers change if we needed two?
This analysis is
It's
not anything to
overall?
do with the
It's
clinic.
overall.
This is just this analysis about what are the impacts to be self-insured. The clinic is a totally separate issue,
Okay.
and the reason there is a connection with the task force wanting to pursue this is because the clinic really wasn't financially of benefit to the district unless you are self-insured. It's much more, it's a greater impact, but that's a totally different conversation. And I would say also, if we decided there was a way to make this investment with that return, I can't imagine that you'd also be wanting to jump right into a clinic, because that also is an investment that takes a while to get the return. So, but this is a separate
I
analysis.
just needed to be clear what we were talking
No, I
about. 'cause
understand.
we
Yeah.
started off with one,
Yeah.
and then we went to
No,
the
I
other.
understand. Right.
One could assume that they were connected together.
Yeah, I'm glad you clarified that too, because I was looking at that. So like it would be a step. Well, it would take time to set up the clinics anyway.
Mr. Kovach?
How does self-insurance, being self-insured, affect the, like with Blue Cross, we have network service providers. We have providers you can use and providers you can't use. And I know Blue Cross negotiates the fees that those particular providers charge or get reimbursed for. How does being self-insured affect that? Obviously, we wouldn't be in the same service provider network. So do you have a read on whether there'd be more service providers or less service providers, or?
Well, I think that falls within your administrative services agreement. Is that correct? Yes.
So
It
they
falls-
would be negotiating with the in-network service providers and so forth, like
Correct.
Blue Cross does.
We've had a lot of local Sarasota County doctors that have been dropped from the network. I was just making an eye appointment. I had to go to about 6 doctors to find one that covered the plan. So, and that was, not normal in the past. So, that's of concern.
Right. And there's quite a bit more plan design, plan design flexibility within self-insurance. Within a fully insured plan, you have to fall within the plan designs that have been filed with the state of Florida. So within Florida Blue's plan designs, when you're self-insured, you can design your own plans. Of course, administration costs become more expensive if you customize your plan to a point where it becomes all-encompassing to administer something like that, but there is more flexibility available.
Right, because I do know, like Jane said, that I've seen it affect me personally where they would no longer, and I know with the Affordable Care Act, if you liked your doctor, you could keep them. But I was just curious if you could do it would it actually potentially expand? That was a joke, by the way. Would it potentially expand the service provider network?
I mean, you could if you wanted it to. I mean, anything like that would require, going out for an RFP, similar to what we did when we went out the last time to do our fully insured plans. Of course, network disruption is a big component of when you contemplate any change. So that would be a big component of this one, too, if you could accommodate our current set of providers.
The difference, are you finished?
Well, I'm just, the last comment, I'm just amazed when you look at the reimbursement fees with Blue Cross, what some of the physicians are, it's just like 85% reduction in their norm. It's just amazing what some of those things are.
Mrs. Brown?
True.
So we would still get like an insurance company to process all the claims.
Correct.
And the difference between that and being full, we would assume the costs or the risk.
We
I'm
assume
not
the
quite
risk.
sure. Versus
We pay the claim,
we pay the claims rather than just paying.
a premium. So we've assumed the risk.
And that $5.8 million that's used for administration right now,
Is
that
we
cost would go away, or
Not
or
all of
we
the
would
cost.
we would
be paying those costs directly. Some of those costs, the fees, the healthcare fees, we wouldn't be paying the premium tax other than on the stop loss premium.
right.
We wouldn't be paying,
And we wouldn't be paying claim by claim. I would imagine we'd be paying on a weekly or
we would
monthly
receive a billing from whoever is administering the plan, and we would work out an arrangement with that particular institution to get them paid for the claims that they're paying on our behalf.
okay.
Okay. So ultimately, yes. So the payback period for making that initial investment of the reserve fee is, 2 years. But you will see savings for assuming that risk year one. So that was what I wanted to show there. Again, I think we've kind of discussed some of these things, but again, the difference, we wanted to kind of show the difference between self-funded and fully insured. Again, cash flow, the district retains its cash until the claims are paid versus making a premium payment every month to Florida Blue. The benefits, you have more flexibility, like I mentioned earlier, with the plan design versus falling within the parameters of state-filed plan designs. The wellness and on-site clinics, the savings come directly to us versus the savings to Florida Blue and hopefully mitigating future rate increases. We are responsible, though, for all actual claim costs, and versus just making a premium payment to Florida Blue, and they're responsible for it. The state premium tax, we were talking about the taxes. We only have to pay it on that stop-loss policy versus the entire premium that we pay to Florida Blue currently. Again, claim runouts are responsibility. We have to pay all of the claims versus Florida Blue's responsibility. We are the fiduciary. We're financially responsible for the plan versus the insurance company, and of course the reserve requirement. So those are the differences. So that kind of covers the whole thing on self-insurance. And so I was going to kind of roll over into where we think we're going to be for next calendar year for our health insurance renewal and where we're kind of trending or where our claims are coming in. So we're kind of estimating that our health insurance is going to increase by about 10%. That has been included in the budget for next year. We think medical costs will increase about 6.7%. Pharmacy costs about 8.7%. This is on a per member basis. Florida Blue's administrative costs are estimated to increase by 10.5%. And the Patient Protection Affordable Care Act fees are included in that part of the renewal projection. Some key factors that impacted this increase: we did have more employees covered under the plan this year. We're up to a total of 6,979 covered members. Our claims increased by 9.6%. Our high-cost claimants increased. We had 10 more high-cost claimants, which is those who had claims exceeding $50,000. And those particular claimants, their claims themselves rose. They represented about 33.7% of all paid claims, which is greater than what Florida Blue traditionally sees of about 30% for those that they cover. So it was a little bit higher. And the pharmacy.
And does that affect our percentage going up next year?
Yes,
That's what I thought.
impacting our increase. Our pharmacy costs increased by 14.3%, and our specialty drugs increased quite a bit. They went up by 26%.
Mitzi, is there a rationale that you can explain on the administrative costs going up 10.5%? I mean, if you look at the number of employees, it's very, very small. Why is Blue Cross or Florida Blue regulated on their administrative fees, or can they pretty much charge whatever they feel like charging?
I guess they can. You want to cover that one for me? Because I've got a feeling it was.
I mean, 10.5% in this economy is a big, for administrative fees, is a big. If we had a lot more employees, it would make sense, but it doesn't make sense to me based on the fact that we pretty much have the same number of employees, yet they're increasing it that amount.
So the first question you asked was about the regulation. There is some regulation from healthcare reform that 85% of the premium paid to Florida Blue has to go to paid claims. So if less than 85% of that, and this is on a book of business across their whole book, say 83% goes, then they have to rebate that back to their clients. On this particular 10.5, there's actually a word, it should say increase to 10.5%. It's currently at about 10. So it's really only going up to 10.5, driven by the healthcare reform fees that they have to pay.
And it was, okay, 210, okay.
Did we get some money back last year?
2 years ago, we received money
ago.
back. This past year, we didn't receive any money back. To 10.5. Okay.
Right. So there's missing a word in there.
Sorry. To 10.5%. Apologize for that.
So it's going to increase from 10%
To 10.5.
Correct.
I was going to say I thought it was their share of the healthcare reform fees.
Right,
also.
and that small increase is because of the healthcare reform fees.
Okay. So, and then of the high-cost claimants, 6 of them are COBRA, 13 are retiree, and 86 are active employees. So, so then just to give you a general idea of where we're seeing the increases, the top 5 diagnostic categories were neoplasms, which were breast, lymphatic, colorectal, and lung cancers, which were 16.8% of our total claims. Musculoskeletal, osteoarthritis, and diseases of the back, spine, disorders, and bone deformities were 10.9%. Circulatory system, were 6.5% of our claims. Digestive system was 6.1%, and injury and infectious diseases represented 5.8% of our claims for 2013. So now we get into the Affordable Care Act. So, yes. So the fees that we will see are the transitional reinsurance fee. This fee was created to stabilize the premiums in the individual market. Basically what happens is that people are able to select different insurances, and so what could potentially happen is an insurer could end up with a disproportionate share of high-risk individuals. So this fee was kind of established to help offset the risk of these high-cost claimants to those who are receiving them. So I think it was supposed to be, what was it, $25 billion ultimately is being collected over the next few years to help offset and kind of equalize or stabilize the marketplace. So the transitional reinsurance fee is being collected for that purpose. So that for 2014 is $63 per member per year that we're paying. And for 2015 will be $44. The Patient-Centered Outcome Research Institute, which is we call PCORI, we're estimating it to be $2.16, is to fund research that evaluates health outcomes, clinical effectiveness, and the risk and benefits of medical treatments and services. Basically, this information is being gathered to allow consumers to make informed decisions on their health care. And then the last one is a health insurer fee. This is only charged on fully insured plans. It's 2.3% for 2014. We think it'll probably be about the same for 2015. And this fee is what funds the subsidies paid out of the exchange.
And the 2.3% is 2.3% of
Premiums.
of our premium,
At the annual premium.
which is a lot of money. Okay.
That's what makes it so affordable, Jane.
The final item is an excise tax that goes into effect in 2018. It's a 40% tax that will be paid if the cost of an individual plan exceeds $10,200 or family coverage exceeds $27,500 in a year. Unfortunately, what's included in that calculation is the flexible spending account, which is a voluntary deduction that an employee can elect to save for their health medical expenses. You can take that money, make that election pre-tax up to $2,500, and then, turn in your receipts to get reimbursed. So unfortunately, if that is included and we get towards that threshold at some point, we may have to have a discussion in the future about whether we need to make a modification, plan design modifications, or we need to modify our flexible spending account contribution limits, or, it's very silly. Hopefully things will be changed and looked at. I mean, it's 4 years down the road. A lot of things have happened in 4 years since Affordable Care, so hopefully things will change as we go forward. But
Is that a static number, or is that indexed for cost of living increases or whatever?
we're hoping everything will change by the time 2018 gets here.
Unfortunately, they don't always change for the better, though. They sometimes change for the worse.
Mm-hmm. Also, as part of the Affordable Care Act beginning, it was actually effective in 2014, but these particular payments don't become effective till 2015. But for 2015 and after, Sarasota County, actually, all employers are required to offer a minimum essential health coverage to their full-time employees and dependents, and the requirement is the coverage must be affordable and provide a minimum value. And the full-time employee is defined as an individual who works an average of 30 hours per week during the measurement period. For us, this measurement period is October to October so that it can line up with our open enrollment period, because there's an enrollment period which can't be any more than 90 days before the coverage begins. So it actually is some strange date in October, like October 4th it's very strange. So none of it exactly lines up with a calendar year, even a calendar quarter, or even our fiscal year. So just trying to get the information out of our payroll system is a bit cumbersome. So we're still trying to work through all of the logistics of even getting the accurate data to work through all of it. And so we're still trying to just kind of get all of the information together, see who's qualifying or not qualifying. But based on that, there are two forms of penalty. There's a failure to offer penalty. We are not even remotely close to being, it's also called a doomsday penalty. And that penalty is a monthly penalty of 1/12 of $2,000 for every employee, minus the first 80 in 2015 and then 30
Does this,
after that or
does
something.
this line up anyway with the federal, their fiscal year? When does the federal start?
No.
Isn't it? Is it October? And when is?
I don't know if it's July or October 1st. I'm not sure which one is the federal. No, the measurement period for us, it's no.
Now, Mitzi, is this a penalty or is it a shared
Well,
responsibility?
they call it a shared responsibility payment because it is also something that can be imposed on an individual who fails to obtain insurance. If you don't have insurance as an individual on your income tax return, you will be assessed a penalty. It's not a tax. It's a penalty. So that's why it's called shared responsibility. So as an individual, you have also a responsibility to obtain insurance. So there's a failure to offer penalty or a doomsday penalty, and then a targeted penalty, which is 1/12 of $3,000. And so there may or may not be a penalty involved for us. We're still kind of working through that piece. And
Although we
we
know
have
for
to do-
sure the failure to offer penalty,
The failure to
that's
offer penalty is not-
doomsday penalty is not. We will not be.
we offer
subject to
minimum
that.
coverage. We have, we give our employees insurance. We have minimum value, minimum essential coverage. It's, it's affordable because I get coverage. It's not. That's not even in the.
What about an employee who is covered under their spouse's plan?
We don't have to worry about them.
We don't have to worry about that. We still have to offer, basically, if we cover our employees, we still have to pay for them even though they're covered under another plan.
No, they can
We don't.
elect to waive coverage. Because
They can waive coverage and we won't be penalized.
Correct.
Okay.
If they have coverage elsewhere and they've chosen to waive their coverage, that's absolutely fine. Okay, so that's enough of the Affordable Care Act. So on to fun stuff. Let's talk about wellness. So for 2013-14, we've continued our wellness program. We've continued to promote participation in our $50 incentive. We have created wellness champions at each of our work sites, and these particular champions are working on our 14-15 plan, and they've had one meeting or two meetings. One. There we go. This week we have one. So some of the accomplishments of our 13-14 program, again, are the wellness champions. The participation in our wellness incentive, we increased by 34% this year. Our preventative screenings have exceeded Florida's book of business. We'll go through that on the next slide. Our flu vaccine was our #1 brand drug for our prescription medications. We had 1,304 flu vaccine claims, which was wonderful. A part of that is Lynn Peterson partnered with Walgreens to make sure that we were able to get our employees the flu vaccine, which was great. And then also, since I'm on camera, I'm going to take this opportunity to promote our diabetes program that we have. If you are diabetic, you have the opportunity to get all of your testing supplies and your medication for free. You just need to be qualified and go through a short education program. So please take advantage of this wonderful benefit. These medications and testing supplies are not cheap, so if you can get them for free, please do so. So I wanted to take advantage, get that plug in there. And we have our employee interest survey should be going out very soon, and we're going to use those results to help us develop next year's program. And also, just as I was saying, we were talking about how our particular screenings, preventative screenings, had exceeded Florida Blue's book of business. As you can see, our wellness exams, mammographies, cervical screenings, and colorectal screenings all were in excess of Florida Blue's normal book of business, which I think is wonderful and shows that we are getting the word out there. So those were good things, all good news. So for 14-15, one of the things that's changing is that Susie DeBose will be moving over into my area from Human Resources and coming to work with Lynn Peterson in Risk Management. I think tying wellness in with employee benefits, I think, is a good way to kind of get those two pieces working hand in hand and getting the program to be a bit more robust and getting Florida Blue and wellness and everything all working closely together. I want to hopefully expand our incentive program so that we can, what I've told them is I'd like to turn our wellness program into like a frequent flyer program, where you get your points and save them up and get rewards and stuff. But again, it takes a lot of effort and a lot of work, and we're a one-man band right now, so it's a little bit difficult. But there are companies out there that kind of do these programs for a living. They're experts at it, and so there may be some benefit to investigating, looking at some of these entities for doing these things. I think there may be a benefit, too, for our employees. It puts it out of the district's hands. And kind of separates it into a third party where they can maybe go online and do this stuff, and it makes it less about the district imposing stuff on them or feeling like we're looking at their information, because that's not really what we want to do. We're trying to help modify their behaviors and improve their health. That's the purpose of this. It's not for us to
Punitive.
spy on them. So we want to maybe look at that and then maybe allow Susie and her wellness coordinator role to be more in delivering programs and educating the staff. So we're going to kind of take a look at that and see what the cost of programs like that might be. And, and as we go forward, if it's a self-insurance program or an RFP that we do for administration, maybe rolling the administration of something like that into something along those lines also.
Is that something that Monica DeJean and her company would do?
I'm not
Remember I introduced you to her?
They do have programs like that.
Okay. So it would be somebody we could speak with for sure.
Okay.
Okay. So then going into some other cost reduction ideas, something that we have done currently or have begun to do is, I'm going to skip the first one, is to educate our retirees and COBRA participants on other options. Currently or before, the only option we had for our employees was our current plans. By Florida statutes, we have to offer our benefits to our retirees. If they make the election to stay with our benefits, then they can stay on our plans, which is fine. And obviously you have to offer COBRA. But we had nowhere else to steer our employees. Now there is the marketplace. So we can offer them other options or show them other options that are available to them that may be more affordable or may be a better option or a better fit for them. So we're just trying to make sure that we can educate our retirees or our employees who are no longer with us on what options are available to them so they can make a better or more informed decision. We do want to expand and enhance our wellness program. That'll hopefully be able to drive our costs down. And then what will require some negotiation, although I will tell you that the union leadership has been amenable to this, of course, given the right circumstances. But is to discuss some default medical plans or some changes to our medical plans. I know Pat is very much wanting the employees to have at least, go get a checkup every year, take a health risk assessment. And so there's been some talk, would it be a bad thing? Obviously we have to negotiate these things, but this is the coverage that you get, and then you bring me, or you bring proof that you've had, or we run a report or something that shows that you've had a physical or some form of a wellness exam, and you've completed a health risk assessment or something, and then you can sign up for any plan. Or if you're a smoker, you default to this plan, and then you enter a cessation program. Or, Affordable Care Act allows you to charge a 35% premium, which, 35% of zero is zero, but, a 35% premium on your medical. So there are different things that you can do to your medical plans to help modify behaviors that could help decrease expenses also. So those are some other options.
Doesn't I think the county and maybe the hospital has plans where, the deductible is probably raised than what it is, but if you're not a smoker, you get a deduction on that, or is it a deduction on a copay or something like that, where their financial incentives of what your annual out-of-pocket would be for premiums, deductibles, or copays, or whatever that happens to be. I'm not quite sure what it is, but I know it's a financial incentive to have people do their wellness checkups and to quit smoking and to control their diabetes or whatever.
Mm-hmm. And I think there are plans in the wellness program to offer like the points to earn financial incentives for those things also. So yeah, you can modify the plan design to make it so that you have different plan designs. I think there are some school districts that have, which one is the one that has Charlotte? That have very severe, very large differences in between smokers and non-smokers also. So there are many things you can do for those things. I think, for us, it's just that we would like for employees to get a checkup every year and just make sure that you're healthy. It's nothing better than to be preventative medicine is always better than reactive medicine. So we would just prefer that they do that piece. So those were just some ideas for us. And then the last one was just some next steps. I did want to let you know that we had a financial advisory committee meeting last week, and we were talking about things for them to look at or where to go. They are interested in looking at our investment policy in addition to this and some other areas, but they did express an interest in this. And, in 2011, they did look at our health insurance and did a lot of work on that, and that yielded us a 9% savings in health insurance. So I'm very excited that they expressed an interest in looking at health insurance again. So I think we'll be kind of taking this presentation and what we've done as far as research on self-insurance and on-site clinics and the different things like that to the Financial Advisory Committee for them to do some work on, and then we can bring their findings back to you guys too, and work on this some more and get some more data. We will get you some information. Well, I'll definitely be able to bring back to you guys the self-insurance, the districts that are self-insured and not self-insured.
I think that would be very helpful to us. And this is a big ticket item. We can't afford with this increase, or looking at this increase, which I can't seem to think that it will decrease from that 10%. We can't afford to not look at this. This is, besides salaries, the very largest part of our operating budget, and we really need to get a handle on it. Mr. Kovach?
Well, and I agree with what you said, and obviously the $6 million initial investment in the reserves is a big stumbling block. However, we do have healthy reserves, and that would be an area that I would at least be willing to look at, because basically you're loaning the plan the money for 2 years, and assuming you're going to get it back in 2 years, and then hopefully you'd have some kind of a ceiling on the escalation your health care costs, assuming that what'd you call it, the Affordable Care Act, doesn't continue. We know that it's continued to change, and I'm sure it's going to get even more affordable than it is now. So, it might be a way for us to at least be able to, put some kind of a cap or a ceiling on this escalation of our costs.
Does all this have to come out of our operating budget? Can any of it come out of capital?
Basically, it has to be general operating dollars.
Hoping.
So our thought is that we don't expect decisions to be made at a workshop. I don't anticipate any change in our fully insured status for next year. However, this isn't something you do quickly. So this is a preliminary step to bring you this information. We will gather some additional information relative to other districts with the idea that if we are going to look at a possibility for the following year to look at a self-insured model, that we have to really do two things that are critical. We need to anticipate an RFP so that we understand what's out there and what might drive some of the administrative costs, and that needs to be put into the thought process as you initiate the budgeting process, because that first hit needs to be incorporated into our budgeting process. So if there's enough interest, given just as we incorporate frequently the budgeting process at each workshop to give you an update on the status, I would suggest that perhaps, even if it's just very limited in the time it takes, that we have this be something that is ongoing discussions with the board, so you move with us, and as the Financial Advisory Committee does their deliberations, that they would report to you what they're finding, so that we really have a focused effort in this area, so that you feel comfortable with any decisions that might be made for the following year, knowing that it's, although this is specifically not bargained, it is a significant impact that we want also to be very visible and transparent to everyone, our employees, the union leadership. Everyone needs to know where we are and what we see as the benefits long term for the health of the district.
You just said that it's not specifically negotiated. Can we make a change like this without? Because obviously then we would want to know before you go down that road that they would not put up red flags or block it. But
our plan design, there are certain aspects of our healthcare benefits that are negotiated in this district, that are part of the contract. Because this doesn't necessarily impact what the employee receives and their benefit, it impacts how we structure that process, which is not something that is bargained.
So it'd be similar to if we changed from Florida Blue to another insurance company, as long as they were getting the same benefits, then.
Or our part, even that probably has even more discussion. But I think it's important, even if it doesn't have to be specifically bargained, that this be a very visible process where they are a part, and we've set the stage for that, so everyone sees. Because it's not in anybody's best interest to pay more than what we need for what we all agree are levels of benefit that we feel our employees should have. So I think everybody has a common goal, and we need to have a very good analysis of, if we structure this differently with a certain level of benefits, how can that help the health of the district financially?
It's much better to have everyone buy in and be part of the conversation before we begin the conversation, because this guarantees success.
Yeah, Pat and Barry were members of the task force, so they have sat in, and they were integral parts of even the creation of the presentation. Pat's out of town, or she would have been here, and they both agreed. We all have agreed that 2015 is just too fast to even try to get it done. So knowing that 2016 gives us plenty of time to get, if we want to proceed or kind of even look at going forward with this. I think they were both on board with looking forward or looking at if we wanted to go towards a self-insured model. They both were on board with that because they realized that there was a payback. You know, there's a big initial investment, but there was a potential for a return or a savings to the district. So I think, you know, they understand that, you know, 15, we have to have a plan to Tallahassee by July 1st and, you know, just trying to get through all of these other things. And there isn't enough time to get something set up and in place for us anyway. But that they're more than willing to want to discuss that openly and work towards something. So they were quite amenable to that, which was wonderful, and they were very involved in this process, which was great. So I think it's all been very transparent and has worked quite well.
Moving forward, I am.
I think this is good.
I would like to see, too, if we're going to be looking at what districts have it, and if there was anyone that started it and that turned back and said no, those that have, maybe get some feedback from either the CFO or somebody.
Yes, that would be very helpful.
What were the pros and what are the cons? You know, how long it took you to recoup, and you know what surprises they might have found when they were doing it. You know, I don't want to be too. I mean, I do want to know the dollar amount, but I want to know if there was any surprises or cautions that they would ask us to watch out for.
Charlotte County is not the same size that we are, so we were looking at a much smaller district. Right. I'd like to see the districts that are close,
like a Marion
in size
or Collier
to us.
or something.
Mm-hmm.
And I think we'll also do some research on the RFP.
Yes.
To get some examples, to get some experience of districts in that process, so that prior to that you'd have a chance to really review a potential RFP.
Okay. That sounds great.
Any other questions? Is that it?
I think that's it.
Thank you very much.
Thank you.
Right on time.
Wow, look at that.
And next
Well,
we have our budget update from Mr. Al Widener, brought to us at great expense. I always think that somehow is significant.
Well, good afternoon, board members.
Good afternoon.
What I've presented, or what I have to present to you today, is where I believe we're going to end up for this year, the 13-14 year. And then I'll go into the 14-15 budget that we just received, the final conference report late in, or for the first week in May, but late in that week. So with that said, I know I've got things written on the first page in executive summary, but I'm going to basically save that as we go through. So, so what I'm going to do is actually start on page 2, because I want to update you as to where we believe we're coming in this year. This year, just so you realize, personally has been a very difficult year. They changed the funding system to whereby you only get the funding for a student of 1.0, and if that student might be in a virtual classroom somewhere else or taking a class outside of our district, we lose the proportionate share of funding. With that change, what happened was we didn't actually get the proration of the FTE until in December, early January. So what that did was it basically pushed behind the 14-15 projection, because I have to use that to go forward. And it also resulted in some surprises for this year as to our funding per se. So with that said, I'll go through the revenues first. And what I've been doing each workshop is I've given you what I gave as a projection for the last workshop that we discussed this information and where we are now. So you'll notice the one column indicates that on March 18th, those are the figures I gave you at that time. So now, in comparing things to the original budget, your federal direct into the general fund is going to be an increase from the original budget of $108,000. I had a little bit higher as of March. The state revenue decrease went down to a decrease of $1,046,000. As of when I discussed it back in March, it was $1,005,500 there, and so we came in a little bit better. Actually, though, in the state revenues, I was hoping to come in much better, but we had what they call a proration of funds that was made of $51 million, and that was done in what they call the fourth calculation. So that netted about $800,000 that we did not receive this year because of the proration they did. And the reason they did the proration is when they make the education appropriation in the spring of the year, that sets the cap. And if for some reason more students show up within the state or whatever the reason is, and the funding would need to go up, that because they've capped it, what that means is they then prorate and every district takes a reduction. So and this is one of the larger proration downward we've had, 51, as far as statewide, 51 million, and to us was about 800,000.
Does that mean our enrollment went up?
Yes, our enrollment went up. Actually, in the February count, it went up about 200 students.
In public schools or charter schools?
It was mainly in our public schools.
Okay, great.
Yeah.
Good to know.
So, and actually what we're seeing, just talk about that for a moment. Our South County area seems to be growing. And because in talking with the principals down there and other people, the builders that still, or that survived, like Waldemere, I think one of them, they have more work than they can handle right now. And so the housing starts and so forth and the foreclosures and so forth seem to be working their way through down in South County. So it won't surprise me at all when we do our 5-day count that our South County may grow more than what we have projected for right now.
That's the only place they've got to build, so
Yeah.
I'm seeing a lot of it.
Was that cap on our district, or was that proration statewide? Statewide. So it didn't matter if our district increased more than what we thought.
Right.
It was the statewide decrease,
Right.
increase that caused the decrease.
Correct. Then our local...
This is probably a stupid question, but, they have a cap. If you go under it, do they then spread out those extra funds?
And you know the answer.
No.
And that is no. No, if they're under, it goes right back into their fund balance so they can reappropriate it for the following year. And there have been years that they've been under, so anyway. Our local sources, I show that coming in about $3.5 million above original budget. And the main reason for that is we're only allowed to budget 96% of our property tax revenues, and we normally collect somewhere around 97.5%. So right now, based on the collections so far, I'm projecting that's what's going to happen for this year. So net increase in revenues of $2.6 million. Then we get into the appropriations and salaries. I'm projecting that to be about 2.5 million, almost 2.3 or 2.6 million below what the original budget was. And a major portion of that was the bonus money that the state gives out based on A schools or climbing one letter grade went down. So because it was budgeted for like 3.1 million, and it came in about 1.8 million. So that was a decrease there. And again, that's because of the grading system, the way it changed this past year. So not as many. We have a majority of schools that did get it, but at the same time we had some that fell off. So then our employee benefit increase. Right now I'm projecting that to be about 1.6 million above what was in the original budget. Part of that is because of the way the teacher raise money was given. I budgeted the whole thing in salaries at that time because I didn't know the exact breakdown. So some of that is related to that. And then also, as Mitzi just stated in your prior session, the number of people we have on our health plan has increased. So that has increased the group health insurance.
Before you leave that page out, my question really is on the local revenues, and really just because I'm curious about it. I know we budget 96%. You said that ultimately it ends up being 97 or 97.5%. Where does the other, because if you don't pay your property taxes, they sell it at sell the tax deed so that
Correct.
the money's, so where does, I'm just kind of curious where that 2.5% goes.
Well, everybody gets a discount of 4%
Okay.
if you
There
pay
you
in
go.
November. So, yes, that's the discount. And, of course, not everybody pays it in November. And there are a lot of, especially retirees, who basically pay on a payment plan. And and they don't get the discount if they're paying on a payment plan.
I'd say, so the pie's still 100%. It's just that discount you get for paying at the end of November instead of paying when they're actually due in March is where that,
Correct.
I just wondered where that 2.5%,
Correct.
3% went.
Right, right. Okay, with that, I'll go on to page 3. In the purchase service area, I'm projecting that to be about $1.3 million above the original budget. And most of that is within professional services, our maintenance expenditures, and then in other purchase services. They have went up more than what I had in the original budget. Energy services going up about $900,000 above the original budget. Majority of that is fuel costs, and part of that increase also is that this year we asked all the athletic programs and field trips and all that they begin using our school buses and shifting away from charter schools and or charter buses, excuse me. So that has had an impact on raising the fuel costs also. Materials and supplies, based on results of operations through April 30th. It looks like we'll come in about $400,000 better than the budget. Capital outlay looks will come in about $347,000 better than the budget. And other expenses, just a small, exceeding the budget by about $37,000, and that's basically in dues and fees. So with that said, your total appropriations by object, I'm estimating right now, will be about $510,000 above the original budget. Then at the bottom of page 3, I get into your gross fund balance, and we began the year with a gross fund balance ending as of June 30th, 2014, of $44.2 million. Then we add in the estimated revenue increase of $2.6 million. Then we take away the estimated appropriations that are going to go above the budget by $510,000. We did have a one-time this year transfer in from the racetrack revenue bonds because they were fully paid, and so we were allowed to put that into the general fund. So $812,000. So ending gross fund balance as of June 30th, 2014, of 47.1 or almost 47.2 million in your gross fund balance. Then, as far as the your unassigned fund balance, the amount that we're projecting based on operations through April 30th, 2014, that will have unassigned roughly $36.7 million or 9.42%. Now, just sticking with what can happen this year yet, we still, of course, have to wait to close the books, and we have to see what actual tax revenues we do get, collections from internal accounts and so forth that are due to the general fund, and basically just closing out everything. So there could be some changes. I'm right now projecting there won't be any material changes, but the number will change based upon once we get the books closed sometime in late August. And of course, then your final budget will reflect the actual final results of operations from the 2013-14 year. Now, starting to go into 14-15, the final conference report was dated April 29th. The one thing I want to go through is some of the still unknowns at this point in time. The conference report has our tax roll going up a little over 6%. Our property appraiser, June 1, will give us the preliminary number that they have, and we'll have to see if that's relatively the same. It's actually July 1 that the property appraiser actually certifies the tax roll. And then once the property appraiser certifies the tax roll, then the DOE will compute our required local effort. Because right now, the required local effort